I'm going to really give you a glimpse of where healthcare reform may happen and effects on you all that are out in the field. Many of you do know that our governor is a emergency physician, and frankly, that has been a major advantage to us in the actually moving forward with healthcare reform. Regardless of what you actually think about the ACA, for us in Oregon, healthcare reform is here to stay. And we've actually had a long history in Oregon, not doing it by the book. And we're like a teenager. If you tell them one thing, we'll do the opposite thing as well. So Oregon in 1993 actually initiated healthcare reform in the area of access to care and basically limited the benefits of access to care, thereby increasing the amount of people eligible for the Oregon Health Plan and benefits as well. The problem is, all you all do know is that the healthcare spending in the United States has gone logarithmic, and we cannot maintain that pace for very long. And Oregon has realized that. What you can see pointed out in red is the major increase in billions of dollars just in Oregon alone in healthcare spending in the United States. So something had to give. So in 2012, CMS, as most of you do know, put out a RFP for innovative programs. And Oregon and the North Willamette Valley submitted their RFP and actually was granted by CMS to actually develop an innovative program that may actually provide the basis of how healthcare reform will be practiced in the future for at least a different portion of the population. What's really different in the Oregon experience is that we are really not talking about insurance. What we're really talking about is a revolution in the way that healthcare is being delivered. The point is that there needs to be coordination as well as efficiencies and decreasing the redundancies and the wasted care and the revolving door that occurs in our patients that we see on a daily basis as well. So what you actually see here is the estimated funding amount in an amount of $17,000. And what's really remarkable is the bottom area highlighted in blue is that I've been practicing emergency medicine for about 30 years as well. And it's the first time I've actually been involved where the payer, all the providers in the hospitals, and I'm talking about all in North Willamette Valley and the Portland area, as well as public health, actually sat down at the same table, agreeing with the same principles in the same way going forward. So this is remarkable, and frankly, I think the governor had a lot to do with it, bringing people to the table. So that really did require that to occur. This is acronyms, and there's a federal government acronym. CCO is our version of the ACO, where it's really a network of all providers who actually are counted to receive the Oregon Health Plan. When I actually say network, I need to be very precise. Right now, what happens in the United States is I see the person in an emergency department. I say, go to your patient in the primary care, and they call a primary care doctor and says, we can't see you next month. There is no coordination. Essentially, it's like getting on a flight to New York City with a stop off in Chicago on Delta, and then going to United and say, I don't have a flight for you. You have to wait in O'Hare Airport for 3 weeks for you to occur. There is really no coordination in most of the United States where the specialties are linked to the primary care, which are linked with some of the other providers as well. So this is really a coordinated care, almost like a Kaiser HMO system, all embedded into one. This sort of dovetails into Mark's talk, where we're actually focusing on three major areas. The first one is the lower acuity patients, and I'll talk about that in the second one. I don't have definitive information. I'll tell you where we've been. We have some preliminary information on the frequent users, and finally, I'm not going to talk about at-risk patients, but we have some success in that area. This is a repeat of what Mark was really talking about. In particular, I'd like to highlight what's in yellow. In our experience for the lower acuity patients, no access to care, open at all time, unable to see the primary care clinic are the three big obstacles in why patients continue to go to the emergency department. The rest of you all know and heard about before as well. In red is the high readmission rate. We have 2 or 3 programs in Washington County, which is a county just west of us, and they have actually had preliminary success at decreasing remarkably the readmission rate. I'm going to be talking about the lower two in yellow, frequency users and lower acuity as well. This is a graphical representation. On the top line in white is what we call classical 911. If you look at Jeff Beeson's area, you actually see how all the different interventions in red really make a difference to the point of nurse triage calling, our system, lower acuity calling, and integrated mobile health care. So let's see where we're going from that perspective. So our quote-unquote lower acuity was titled Alternate Destination, Alternate Transport Pilot Program, and the goal here is not to deny transport. The goal was here is to put the patient with the right place, right time, with alternate non-911 resources as well. And you can look at the cost and the potential cost savings. Conservatively, it could be as much as in our system, $3 million a year. And these are actually, what you're actually doing is not lowering the quality of care, you're actually saving them out, and you're spending it on the people that you really want to spend it on. And in turn, actually, our ERs are clogged. They may get seen and actually treated in a quicker fashion in the right clinic as well. So what are the components of the goals that we actually have here? The first one is paramedic triage. We had to develop a protocol which was relatively difficult and relatively easy. I'll explain that in a second. The second one is we actually had to find a coordination center. It turns out that the coordination center actually is the one to identify the insurance status, which is key to this pilot. And there's no easy way for our providers in the field to know their true insurance status, as well as coordinating which of the clinics could see them. And finally, we arranged with some of our providers to actually get alternate transportation, and the vast majority of the cases, a cab, not an ambulance, to the clinic. And notice the round trip portion, which was the selling point for some of our patients. They really, really did like it as well. So what did we actually develop? We actually developed the protocols. We actually instituted the paramedic training, and I'm going to go to that training in a second. And we actually identified the non-ED clinical sites, and the vast majority of the cases, these were federally qualified healthcare centers who were actually assigned to take care of the patients. And finally, our healthcare plan needed to get on board. In summary, what happened here is that this is a template where I stole the ideas of the CHAP program, which is home health care in Alaska. And most of you don't know, but I was actually the medical director for the U.S. Wildlife Forest Service, which actually had these protocols in effect for about 20 years, where we actually triaged in the field and actually identified the transport. So this is what the protocol looks like. This is the field guide. What you actually see is cardinal conditions. Under no circumstances do they qualify. They obviously meet all the logical ones: immunosuppressions, older, unstable, as well as some of the social issues, suicide attempt as well. And this list here is really important. It turns out if you look at our list of lower acuity protocols, in yellow are the ones that the paramedics were not familiar with. They didn't have enough education as well. So we spent a lot of time on eye, ear, nose, throat, and dental pain. And this is what the protocol looks like. Example, a sore throat. And if you notice, the protocol actually has history, physical exam, differential diagnosis. This is an intervention where you actually had to think rather than do. You actually had to get a good history, good exam, and actually had to think. And finally, we wanted people in the middle of the night not to make a mistake, so we had a checkoff list. You can't, if you get it in red, you can't put them into the clinic. So the disappointment portion is that we've had a lower enrollment, but we've been able to send patients to the clinic and successfully identify patients with the clinic. Our issue here is identifying them and making sure that the protocols are safe. So that's the real goal. And I have about, so we got wet stuff here. Can you advance the slide for me?
Yeah, fine. Hold on for a second.
How are you doing there? Oh, there we are. So the barriers are identified are lack of insurance, the clinic's not open, as well as the age being older, the older patients. The last 4 slides I have are the frequent users, and dovetail to what Mark really said here. This is a slide indicating that the Medicare population, a huge portion of the frequent users, a small portion of frequent users use the services. Very familiar with that. What actually happens is that the vast majority in the bottom of the care, which is acute care visits, in red is the ERs, and 4% of the nation actually take care of 66% of the poor and non-funded patients in the United States. So what we actually have here is a wraparound service with social workers. What's different than Jim Dunford's program is that this social worker is an EMS social worker in the 4 counties. They're linked with hospital social workers, as well as home outreach, as well as mental health professionals and drug and alcohol problems. So this is basically a wraparound service, and that's actually the key to our success here as well. We've been doing intensive case management on our frequent users, and you see the qualifications on the frequent users here. And as Mark said, 50% have significant alcohol, 50% have health and mental health conditions, and 25% had a primary care provider. The bottom line is in 6 months, we've been able to drop our repeat top 20 users from 432 to 221, with the cost savings calculated at about $1.2 million. Please note that these patients actually got better care because they got treated for the drug and alcohol and their mental health. So they didn't need an emergency department. They just needed a primary care doctor as well. So in summary, I took you a very quick look about what's happening in Oregon health care reform. I'd like to have you leave with 3 messages. One of them is health services, at least in the Northwest, is changing to integrated health service and coordinated care. That actually translated your payment for transportation may change or will change in the near future. The second real summary point is that I think EMS needs to be incorporated into the body of medicine and start doing regular medical care. And the third, obviously, is that our frequent users can be actually addressed, but in a very coordinated fashion. Thank you.